opened it up to the whole school, and we have a school case competition. It's really exciting to be a part of both the local competition and the national competition. So just to reiterate what Lubov said, it's a case competition. I know a lot of folks don't get to do case competitions as frequently as some other people. You'll get a problem. In the past, it's almost always been around patients and patient outcomes, and you'll get 3 or 4 patients presented to you in their history and a little bit of information about them, and there'll be some aspect of adjustment that's needed in the healthcare delivery system. And they always ask you to do a root cause analysis, which is what we're going to talk about today, as part of the Clarion case. And the best part about root cause analyses, who here has done these before? Yeah? Oh, I know you have. So the best part about them is that they're multidisciplinary and interdisciplinary activities in and of themselves. In the Clarion case competition is very strongly interdisciplinary, and so that's one of the reasons why root cause analyses are always asked for in the case. But another thing about root cause analyses is it's a little misleading, the name root cause analysis, and I don't like the name RCA, root cause analysis, because it leads you to believe that there's one underlying cause for whatever this mistake or this event, this sentinel event or this error, that there's one underlying cause and you can find out what it is by conducting an investigation. And that's partly true. You can probably find out what the underlying cause or causes are to some sentinel event or some error, but it's almost never one thing. And we work in complicated environments where in the best case scenario, it'll take a multitude of mistakes or errors to happen before some bad outcome is transferred to the patient. Because we make mistakes, so we put processes around us to try and to double check and guarantee that the mistake won't propagate down the line. And so they call this the Swiss cheese theory. Has anybody heard of this? So the idea with the Swiss cheese theory is Swiss cheese has lots of holes in it, but none of those one holes are bad enough to let water all the way through or let a ball or a pebble pass through the Swiss cheese. The holes have to all be lined up in a row, this perfect storm of bad stuff for an error to make its way through the Swiss cheese. And so, in theory, you could just fix one of those holes and that same event, that same error won't happen again. And root cause analysis is a way to identify what these contributing factors are to an event. I would prefer, I said I don't like the name, I would prefer it be called systems analysis, because that's more of what it is. It's a multidisciplinary way of looking at all the contributing factors that led to a particular event. Now I keep talking about events. It doesn't have to be a sentinel event like the wrong site surgery. Then we convene a multidisciplinary team and we figure out how that happened, how that wrong site surgery happened. It could be something as simple as a missed appointment. It's rarely non-sentinel events because of the effort and the resources it takes for you to convene a multidisciplinary team and investigate what happens. But it could certainly be for a case analysis for a 30-day readmission, or something that isn't necessarily JCO sentinel event, but is important enough that you want to figure out what's going on so you can improve your processes. So the biggest things to keep in mind with root cause analysis is it's system, it's interdisciplinary by its nature, and it's trying to identify all of the underlying causes. And also, lastly, and really important, is that the idea, you're doing this with an eye on process improvement. So if you were doing this for some other reason, to place blame or to identify who's at fault or something like that, you may end up with a different outcome. But you're doing this to figure out ways to fix or ways to avoid this kind of event from happening in the future. if you guys have questions or comments all along, be like, raise your hand because you have food in your mouth, or just point, or something. So like I said, serious adverse events, serious is a little subjective. Most organizations do this process because it's related to JCO accreditation. Really good organizations will do this process as just a continuous process improvement whenever events that pass a threshold of being serious enough for them to investigate. You're looking with this kind of investigation, you look for two kinds of errors, right? Active errors and latent errors. An active error is more of a direct error, like a screw up. A latent error is more something that is embedded in a process, or it's embedded in the system. And when we typically do root cause analysis, we want to identify as many of those as we can in the process of both types. Which of those can you do something about? Active or latent? Both! You can do something about both. And there's lots of interrelationships here. I mean, when we get to what the meat of root cause analyses are, you'll see this tangled web of all these things we're contributing to, and it just happened because so many things went wrong or didn't go completely right and caused an active error to happen. So there's a list of latent error factors. This is important because these latent errors are things that are lurking in processes or lurking in established systems that you have in your organization, where there's management factors, work factors, team factors about communication, staffing factors, specific task-related things, patient characteristics can lead to latent errors. And the categorization of these becomes important only when you're trying to communicate what your findings are to the appropriate person who can come up with a strategy to help mitigate it. So you may want to group your errors by, here are the ones related to HR and staffing that can be fixed with education. Here are the ones that are related to regulatory issues. We have a new policy that requires 80% of our providers to use CPOE, and it's this policy that is leading to alert fatigue, and that's what led to dismissing an alert and giving the wrong dosage, that kind of thing. So you can group them by latent errors, in particular by these factors, and it just helps you stay organized. And I'll talk a little bit more about that in a minute. In fact, right now. Here's another way to group it, and I know these are really hard to see, but I'll tell you right now that there are dozens of different methods and tools to do root cause analysis, and I'll introduce you to 3 or 4 of them. There's no 100% right way for your situation. There may be a right way that your organization recommends. Here's the standard way that we do it, so everybody does it the same way. And one common way of grouping these errors, these factors, is by these 7 groups: human factors, equipment factors, environmental factors, communication factors, policy, environmental risks, and information factors. And so a lot of organizations tend to use these 7 buckets to help guide their investigation. Okay, now let's look for environmental factors, and you do your root cause analysis. Now let's look for equipment factors, and you do your root cause analysis. So it's just a way to stay organized. Any questions about these? All right. Now, this is the shallowest example you'll ever get, and I'm only giving it to you because I want to compare it and contrast it to a conventional investigation. A patient was mistakenly taken for another patient's invasive electrophysiology procedure. So the nurse was tired. She didn't check the armband when she gave it transportation. Transportation didn't check the armband, and the nurse said, take this up to electrophysiology. And they got up to them. They didn't check the name, and they gave them some procedure. that he or she wasn't supposed to get. And so a classic investigation, the old way that you do things, the not RCA way, is they would have said, this nurse totally didn't follow protocol. She knows she's supposed to check the armband, ask the patient their name. Every time she's supposed to do that, she didn't do it, it's on her. We don't do that kind of method anymore because it doesn't lead to an improvement in our system. All it does is blame the nurse. She's going to be reluctant to even talk to quality improvement about this. And at the end of the day, nothing has changed. We just found out who caused the problem. We didn't do anything to fix it. So the root cause analysis, basically, you went in and you talk to everyone and you make it clear. Root cause analysis is a process of doing an investigation, and it's also a way to formalize what you think these active and latent errors are that contributed to the problem. So you do the root cause analysis, you talk to everybody, you make sure they know that, listen, we're not placing blame on you, we're just trying to figure out what happened because we're going to hopefully change policies or processes or whatever caused this to make sure it doesn't happen again. And they found 17 different root causes, and some of them were sequential in a way, like the Swiss cheese, where if one of them didn't happen, it would have been caught by some other process. So they found 17 issues, including misused protocols, poorly functioning teams, no informed consent process, because that could have caught the person as well, and bad information exchange. And then at the end of the root cause analysis, contrasted with typical investigations, is you end up with a recommendation of where you can change some of these issues. It's usually organized by these types, these factors, but not always. You all with me? Root cause analysis, new awesome way, old busted way of just placing blame. Not just the new awesome way, like I said, accreditation is kind of tied in there. The simplest root cause analysis tool you can find is called the 5 whys. Why is it called the 5 whys? I'll give you one why for that. Because you asked why 5 times. Right. Awesome. So, and there's a worksheet for that right in front of you. If you don't have it, I can give it to you. And I've got links for you of where you can get to these different tools. So this is really simple. It's easy to understand. It's kind of an organic investigation, so there are no rules set up for you and your team to follow to do the investigation. But basically, you identify, well, the event has already been identified for you. Something bad happened. There was an HIV needle stick or eye splash. It happened. And then as the root cause analysis would be done in an organization to see how that happened. Aren't you just tempted to say, well, somebody just screwed up, he hiccuped and he got stabbed with the needle. Or whatever else could happen to get stabbed in the needle, or the surgeon tossed the scalpel on the tray. It bounced off. I've been there. And so you're tempted to say, why waste the time and energy investigating what happened because we totally screwed up. We know what happened. When, like I said, that's not part of process improvement. You're not going to make anything better by just identifying a screw up. So you start with a needle stick, HIV needle stick, and you say, why did that happen? Just the first why. Well, I don't know. I guess I wasn't paying attention, and I tried to put the cap back on, and I just stabbed myself in the finger. And then you say, why again? Well, why weren't you paying attention, or why did you stab yourself in the finger? Well, and then you don't want to guess, but you work with the people, and you say, well, maybe it's been what the situation was. He or she hadn't practiced that protocol for a while, or they haven't, they were tired, or it's at the end of an 11-hour shift. And you identify everything that you can that would be contributing to that. And you might stop at the second why or the third why. But for some of these cases, there should be like 17 whys, because there's so many things contributing to the different factors. They get pretty complex. And then at the very end, when you're done, when you get to the point where God made them, and then You know, and that's how it is. Then you stop and you identify what you think the underlying root causes are. It's somewhat, this process is somewhat subjective to some people, and that's why we use a framework, and that's why I encourage people to use the same framework. It kind of takes a little bit of the variability out of it. Y'all with me with the 5 whys? Who's got an example we can use? I have some later, but I'd rather talk about y'all than me.
A wrong tooth has been extracted, and then they told the mom it was for orthodontics, and they told the mom, and then they went back and extracted another wrong tooth.
What? So how did that happen? So that sounds like a perfect root cause analysis scenario, assuming you don't want that to keep happening. Assuming that, because eventually you run out of tooth. But eventually you'll get to the right tooth, and you'll be score. Assuming you don't want that to happen again, you would do a root cause analysis. Remember, this is a multidisciplinary thing because that situation is a multidisciplinary situation that led to that. So describe kind of how that happened. Why did they pull the wrong tooth?
Maybe the student doesn't know how to count teeth.
Maybe.
Or it was listed wrong in the chart.
Maybe. So that you would ask them, and he would say, you know what, I pulled the one that was listed in the chart, but it was listed wrong in the chart. And then you follow back and say, why was it listed wrong in the chart? And you go back that way. Or it could be, I was just reading this other patient's chart. There's a great root cause analysis that gets drug names mixed up. But I was looking at, because we're multitasking and we're working with different patients all at the same time. I was looking at another chart, then I looked back to this patient, and I just kept going where my mind was, and it was wrong. And so you follow that all the way back, and then you try to figure out why they did the next wrong tooth too.
Another cool thing is that orthodontists have a different numbering system than
See, that might be, I mean, with the drug naming thing, very frequently the root cause analysis will identify this drug sounds just like this drug in the root cause analysis. I mean, there's nothing, you don't just put things that you can do something about, you put things that you think contributed to the problem. And so if they have a different numbering system, then that's going to end up on a lot of root cause analysis worksheets of something that potentially led to this event. All right, so we have the 5 whys. We have cause and effect diagrams. I'll show you that. Fishbone diagrams, sequence of events, lots of other custom tools and models. Many of these tools, they don't come with just a diagramming system. They come with a structured way to interview the staff that were involved, a structured way to look through the charts. For the Clarion case, that's not necessary because they give you all the information. There's really no more information about the case that you can get. So you really just need the tool to map the information together and do an analysis of what you think were the root causes. Let's look at another one. Well, there's the 5 whys. So cause and effect is grouped by these different factors that we're talking about. This is a 6 factor. These are 6 instead of 7, but it's the same idea. So they basically, you put the event over there, and you list all of the human factors that you think contributed to that event. You list all of the environmental factors that contributed to that event. If you wanted to get really awesome and crazy, you can put like little segments of causes, something that caused that, and it can get pretty complicated. You guys, how many of you have seen process flow diagrams with like boxes and arrows and more boxes? So that, I'm not showing you that tool, but that's a very common way to express your findings of a root cause analysis. Just the information in the process flow of what led to that. And this is kind of an analog of that. So here is the same chart, just filled in. And you can see they got a little, well, you can't read this, but they got a little crazy here because some things contributed together that led to that, and some things are separate. And that one might be impossible for you to read too. It's another root cause analysis tool, same idea. So, lack of supervision, communication, documentation issues, things like that. And then there are basically just these linear sequence of event charts, almost like a log sheet with time and what happened, time and what happened, time and what happened. That is just another way to express the sequence of events that led to this root cause. This is a tool that I believe is sponsored by Minnesota Public Health, or developed by them, released by them. And it has categories and questions and then prompts for each of those. So it kind of walks you through the process, and I'm going to give you a link to these tools at the end of this. But it basically says, why did it happen? Staffing appropriate, and then you get to the next question that is about something else but not staffing. And it kind of walks you through that. All right, let's look at the case that I put in front of you. This adverse event scenario. So take 5 minutes or so and see if you can do the 5 whys for this case, and we'll talk about it.
Was this last year's case?
No, I didn't bring last year's case. This is just a separate one. Last year's case had 4 patients with multiple chronic conditions. One was a readmit, one passed away at home, and you did each one of them separately.
Can I get a copy of that sheet?
What's that?
Can I get a copy of that sheet?
Oh, sure. No, you're supposed to just think really hard about it. So in real life, I'll just interrupt you for a second. In real life, there would be a sentinel event, which all the information you would have about it is probably that first paragraph. Oh, a 62-year-old tripped and fell in the room and broke her hip. That's what we're doing, right? Yeah. And then the rest of the information that you would find in this would have been up to you to interview staff and write it up and report and analyze it.
Old lady dies.
Old lady dies. How are you guys doing? I see some of you still writing. Oh, don't forget to thank Dr. Alan Dow for the food that you have today, and for this room and everything when you see him.
And Melissa back there in the corner arranged all that.
Oh yeah, Melissa too, it's hard work. So this one's a really simple example that we can do in a short period of time. I mean, you can imagine that when you have the low socioeconomic status patient that is English as a second language or maybe non-English speaker with multiple comorbidities, with transportation problems, and with, on 12 or 13 different meds, and possibly the wrong ones, which would be your typical patient, right? For doing this, it gets more complex, and it gets a little bit more involved. What's the most amount of whys that you guys have on this? Anybody just stop at 1, 2, 3? What do y'all have? And she was born, and it goes all the way to that. So somebody give me an example. What's the problem statement here? What happened?
Death.
She died. Anybody else have a different problem statement?
She falls and breaks it.
Right. So either one of those would have been acceptable. There's a separate, I don't know how much information this case gives you, but the handout that I gave you of the case. But the real case that we're looking at, the death was a separate investigation than the root cause analysis for the falling and breaking her hip. The death was handled separately. So she fell or she died. What caused that? What's another why? I'm assuming if you had that she fell, then maybe the one before that was, or she died, then it was she fell?
Surgery.
I'm sorry.
Surgery.
Surgery. So that contributed to her death. It could have. It could have. But she went into surgery probably because of the fall. And that maybe the surgery could have been an intermediate step in your root cause analysis. What else? Why'd she fall?
The room was messy. There were like tubes and chairs. And
Tubes and chairs? Why were there tubes and chairs? Anybody have the tubes and chairs? Why were there tubes and chairs? That's another why. I mean, should there be tubes and chairs?
Her family was visiting.
Yeah, those families. Her family was visiting, and there were and we also give her plenty of tube so she can get into the chair, and we didn't just give her extra tube so she could slip on it. And so I don't think we need to ask why her family was there. We can stop with that one. But you want to ask why there was extra tube. And there's extra tube for maybe a good reason, but maybe not, because it contributed to her falling, because we wanted her to get up and get into the chair and be comfortable moving around a little bit in her room.
Could you also say that they should have moved the chairs after the family departed?
Yeah, so we haven't got to exactly, yes. And that, remember, I said that we're doing this with an eye on process improvement in the end, so you should be thinking that way while you do this, and save those thoughts for your recommendation at the end, because we're still trying to just get the facts and trace them back. But that would be a great recommendation to, at 10 o'clock we put all the chairs, we take all the chairs except for one out of the room. Or the tube thing, I don't know what you do about that. Anybody else have any whys? Yes, ma'am.
So many.
So many.
Why did the respiratory therapist communicate with the nurse about him changing the tubing? He didn't even document it. About the pain medication, why there was nothing said her.
Yeah, that was a concern for me.
Yeah, 'cause
we have.
if she's on morphine and.
Why did she get a sleeping pill and a pain medication?
Yeah.
Right.
And it
So
doesn't seem-
this was the actual root cause analysis that came from the Minnesota hospital over here. I didn't point it out earlier. Some of you might have figured that out. But this is the RCA that they submitted for this particular case, and I would have been concerned about the pain medicine and the sleeping medicine, but that didn't make it into theirs.
Have they heard of the Beers list? What?
Well, it's Minnesota. They also up there they call it a root cause analysis.
A RIP?
Root cause. Because that's how they talk up there. Yeah, so your list could be pretty complex and long, and you're just doing the 5 whys tool, which is the simplest way to do this. Everybody have kind of a good sense of what this is? So this is just the tip of the iceberg. So as I mentioned, there's lots of different tools. Some of them are very prescriptive. Some of them are more like the 5 whys where they're pretty unstructured. Either one is usually fine. Your organization might prefer one or the other. For the case competition, you do whatever you're most comfortable with or you think lends itself best to the case or whatever. The one official place is basically, there's a journal article on a comparison of techniques for root cause analysis, and it basically just says, does this tool, how well does it lead you to suggestions for improvement? You know, some tools are better for identifying suggestions for improvement than others. Or how well does this tool help categorize the types of errors? You know, so it compares them in that way. The Minnesota Department of Health, I think, is the best resource on this that is out there in the public internet right now. And ARCS is just meh. But let's go there real quick. I wish I could find a prior case that that was the visualization of a root cause analysis. But basically, here's the Minnesota Department of Health, if you can see it. So there's lots of training videos where you can hear them say root cause, and they're really good. I mean, these are usually made by nurses, really wonderful, skillful people and knowledgeable in this area. And there's lots of examples that they use: wrong body part, medication error, pressure ulcers. There's some tools here that are listed for you. You can just do a Google search and you'll find a dozen more tools. And some of them are pretty complex and awesome looking visually, but they're not necessarily better. I'll tell you, for the case competition, if that's what you're interested in, we saw teams with what didn't look like a formal tool for root cause analysis, which seemed to be kind of okay. And then we saw teams with this really UNC had this really amazing tool that was basically a process flow diagram with arrows and charts, but it was divided up into bands where you have like a purple band up here, and the purple meant like environmental, and then a blue band with stuff going through it, and that meant something else. So it gave you like a novel's worth of information in one picture, basically what the root cause analysis processes that led to it, and then what those categories were all in one picture. And I'm not sure that sophisticated means better. It'll be up to you guys. Any questions?
But this section of the presentation is usually the weaker part, you would say, or it sets you up for success or failure for your solution?
Well, what students are really good at is coming up with awesome ideas, reaching for the stars in terms of their recommendations. So you have, in your root cause analysis, you identified a lack of Spanish-speaking patient education capability. And so your recommendation would be mobile health vans with Spanish-speaking workers who are cross-trained in Oaxacan and all this other stuff. So students are really good at coming up with, or they just recently read an article about some amazing program training EMS workers, training EMS personnel on cultural competencies and chronic care education. Well, EMS people don't typically do that. They typically, rescue you or give you a ride to the ED depending on your situation. But now we saw an article on we train the EMS people to teach people how to manage diabetes, so they get dispatched to do that while they're not rescuing people. And it led to better outcomes. And so a student hears that and that's in their mind and they make that recommendation kind of with less regard to how feasible it actually is realistically for that hospital or that case, but it's an awesome idea. I think that's the biggest weakness with student cases, and the judges know that, you know, that students are kind of big thinkers. How are we going to pay for these $1 million costs? Oh, we'll get a grant. That's mistake number 2 is the grant pays for everything. I don't think that the root cause analysis is the weakest part, but I think it's the most heavily scrutinized. Their thought process of the team, you know, and how multidisciplinary it was. We also, no matter how multidisciplinary we try to be as a team, you're going to have a pharmacist that is going to find, he or she is going to say, dude, this is obvious. This person's on all the wrong meds. You know, I can fix this. And you're going to have something else. You know, you're going to come at it with your own perspectives, but you have to figure out a way to make it cut across these disciplines. You know, to be able to all fit together and not just be 3 specialists making a recommendation. And that's another thing that is usually graded pretty critically.
Do you have recommendations for how the students can gain a better understanding for how a hospital system budget works? Would that be just get a MHA student on your team?
Yeah, so I'll say get an MHA student on your team if you can. I don't know what you'll have to do to get them on your team. We have one already. Y'all can arm wrestle over her. Yeah, so that's tricky. I will tell you that depending on the judges, there's a different level of emphasis put on the budget. However, it's still required. I mean, there hasn't been a case yet that didn't require a budget and some kind of analysis like net present value or something like that, which you might not know what that is. I don't know what to say about that. Yeah, if you don't have an MHA person to do your best, you know, that might be good enough. Everything counts. Get some help from a finance person.
And there are faculty advisors that are available.
You were trying to get me to
No, not
volunteer.
you.
Is that what that was? Yeah, there are definitely faculty advisors that can help you. If you know, I'm not a budget wizard or anything like that, but I guess I can help put you in the right direction. Yes. But it's definitely not the most important part, so don't feel like you're doomed because you don't have an MHA person. Any other questions about it? It's really cold in Minnesota in May, if you go there. Some of you will. There's been snow on the ground the last couple of years.
So the logistics about the local competition will be going out pretty soon. It will happen in March, I believe, during the MSwiller Interprofessional Symposium that we have here in Richmond. 28th of March. But teams will be forming either at the end of this semester or at the beginning of the spring semester. So keep talking about it with your friends. The next sort of presentation in a series on Clarion case competition, kind of teasers, is going to be a case study from VCU where I think it's been 10 years since they started it. Well, maybe 20. They looked at high utilizers, people who return to the emergency room again and again, and trying to form a different program for them. So that'll be November 24th, I believe. Look out for it.
I forgot this might be the only time I see you guys before you get a chance to do the case. I'll give you some just general case advice too. So if you haven't done cases before, not always, but they're typically done from the perspective of you being a consultant or you being some expert making recommendations to the organization. So it's really important that you read the case, and this is going to sound crazy, read the case and just do what they ask you to do. So we've had people, there have been people in the past that challenge the premises of the case, readmissions, for example. The case says, figure out a way to reduce readmissions. Here are 4 patients and their stories of why they were readmitted. And the team would spend a good part of their effort in critical thinking showing why readmissions isn't a good measure of quality. But come on, just play. It's just an exercise. you do your thinking, your hard work and your thinking on what they want you to do in the case. You don't necessarily have to show off your perspective on kind of the foundations of the case. Have some budget, keep it realistic. It's totally okay to have the most boring suggestions in the world that are boring to you, because they're not, multi-million, well, I can tell you most of them are going to add up to be multi-million-dollar, even if they're really boring interventions. But, you can keep things really simple and still do really well in this case, because they're looking for a thoughtful root cause analysis. They're rating you on how interdisciplinary and multidisciplinary you are. I mean, that's a real grading thing. So work on that, Don't work on trying to find the latest research on what, New York is doing to help curb 30-day readmissions or whatever. I mean, you could check and see, but if you have a plan that seems to be widely accepted, no matter whether it's super innovative or not, and you think it would work in this case, recommend that. Be interdisciplinary, learn something. Don't kill yourselves on the case. What else? Presentation counts. Go ahead.
I just have general questions about the competition. Do you have a set, you have an hour to figure this out and make recommendations? Is that how it works?
No, you'll have
Or do you
3
work on
months.
it?
Okay,
Oh.
you'll have a case given to you.
Okay.
You'll have a case given to you.
And
Last
you work
year's
on it. Okay.
last year's
Okay.
case, it was pretty dense. It had 4 vignettes of patients, that all had multiple chronic comorbidities, but just had different situations that led to their 30-day readmission. And then they wanted your recommendation to how, I don't know if that was last year's or the year before, whatever, and how to lower the readmission rates of this organization. And it's super open-ended. I mean, you'll have to figure out how to do a root cause analysis and read through these vignettes and say, this person relies on their kids as a translator, and maybe something was lost in translation, or they didn't understand, they needed a follow-up visit, or you'll spell that all out. You'll identify the priority things that you can make a difference on, and we'll make recommendations to fix those things you identified as a priority. You'll have months to put that together. And you'll have 10 minutes to present it. How good you talk, how good your presentation is, your general appearance and your presenting style is almost always graded as well. How interdisciplinary you are is almost always graded. The part of how genius your ideas are is like this much. It's like this much. So don't sweat that stuff. Have just solid ideas and work together, and that's what it's all about. Yeah, so you have plenty of time.
Okay.
And I think what we do here is the teams compete here, and whoever wins here gets sent to Minnesota to represent VCU. And if you win there, you get cash. And it's not a bad case competition. It's pretty much, when you go to Minnesota, if that's somebody you will be going to Minnesota, it's run by the students up there. And so they suffer from lack of institutional memory. So every year there'll be an emergency of whether or not they can allow clickers, because they didn't think of that. And every year there'll be the same old questions, which is, can we hand stuff to the judges? And they're like, I don't know, I didn't think of that. Let's have a quick meeting, and then there's always that kind of stuff. But they're really nice folk.
So they're guilty of not following their own root cause analysis.
Right. Well, they don't do it, Yeah, exactly. Exactly.
Thank you so much, Dr.
You're welcome. And if you have any questions or anything, let me know. I might be able to help.
Everybody has signed in?
Sign in so we can get money for your food.
Thank you for reminding.
No, send more information to you.
Did you do this last year?
I did
So I
not.
was thinking we should.
We were like an assistant or something.